Welcome back, everyone, to part 15 of our 150 parts IPDRG masterclass on Decode Healthcare with Harshal. Last time in part 14, we dug into the really intricate guidelines for poisoning, adverse effects, and underdosing. Well, today, we're completely shifting gears. We are decoding the incredibly specific, sometimes tricky guidelines of ICD-10-CM Chapter 15, which covers inpatient obstetrics and maternity coding. This is just a massive area of inpatient coding, and honestly, getting it right is absolutely crucial. It's not just about accurate clinical representation, it literally drives proper hospital reimbursement.
But hey, before we dive into today's complex coding rules, just a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. It's your support that keeps these deep dive explainers coming week after week. All right, let's take a quick look at today's agenda. We're going over the Chapter 15 overview and core obstetric rules, trimester reporting and seventh character extensions, principal diagnosis selection, common inpatient maternity complications, and finally, reporting outcomes and MSDRG impact. These are going to be your essential building blocks. Let's jump right into Section 1, Chapter 15 Overview and Core Obstetric Rules. So here is the absolute golden rule you have to burn into your memory. Chapter 15 belongs strictly to the mother. You must never ever mix maternal diagnostic codes into the newborn's chart. It's like a giant wall separates them. The mother and the baby are two completely separate patients, right? They have two completely separate charts. The newborns get their own specific Z codes and P codes, but if you're coding the mother's admission, you stay firmly right here in Chapter 15. And this brings us to the priority rule, which brilliantly illustrates just how powerful Chapter 15 really is. Basically, if a condition is the main reason for obstetric care, or if pregnancy aggravates an existing condition, Chapter 15 literally trumps all the other chapters in your sequencing. For instance, say a pregnant patient is admitted for a severe respiratory issue that's complicating her pregnancy. The obstetric code for that complication goes first, and then you sequence the specific respiratory condition. Chapter 15 always wins. Moving right along to Section 2, trimester reporting and seventh character extensions. Timing is literally everything in obstetrics. You've got to be incredibly precise when classifying the delivery window based on the clinical documentation. We define a term delivery as exactly 37 to 40 completed weeks. Hit anything less than 37 completed weeks, that's preterm. Now, delivery between 41.1 and 42 completed weeks is postterm. Oh, and don't forget the postpartum period. That isn't just some vague window. It is strictly defined as the 6-week period immediately following delivery. Nailing these definitions is how you avoid those major foundational sequencing errors. As the pregnancy progresses, our codes have to adapt to match. The first trimester is anything less than 14 weeks and 0 days. The second trimester, that runs from 14 weeks and 0 days to less than 28 weeks and 0 days, and the third trimester kicks in at 28 weeks and 0 days, lasting until delivery. You've got to make sure your clinical documentation perfectly supports these precise timeframes. Now, you are going to rely heavily on that seventh character extension to paint an accurate clinical picture, especially when you're looking at twins or triplets. In Chapter 15, this seventh character is a real game changer. It doesn't just specify the trimester. In cases of multiple gestations, it tells us exactly which fetus is affected by complication. Like, is this issue happening to fetus 1 or fetus 2? That little seventh character tells the whole story. Okay, listen closely to this one. Never close an obstetric chart without double-checking for a Z3A code. Capturing the exact gestational age is an absolute non-negotiable requirement. Category Z3A is a mandatory secondary code on all maternal records. Just knowing the trimester isn't enough. We need the precise week to ensure total accuracy for the inpatient admission. Up next is Section 3, Principal Diagnosis Selection. This is arguably the most important decision on the chart because it drives the entire MSDRG grouping. Clinical presentation completely dictates your sequencing here. Code 080, that's basically the unicorn of maternity coding. You only ever assign it for a single live-born, full-term vaginal delivery with absolutely zero antepartum or postpartum complications. Textbook perfect. But look at scenario B. If there's even one complication, like preeclampsia, premature rupture of membranes, or a severe laceration, 080 goes right out the window. That specific complication steps up and becomes your principal diagnosis. So think of this as your go-to coding algorithm. Step 1, sequence the complication first. Step 2, document the time with Z3A.
Step 3, report the outcome with Z37. If you follow this strict 1, 2, 3 logic, your sequencing for complicated deliveries is going to be bulletproof every single time. And hey, if it's an obstetrician admission without a delivery, say for severe morning sickness or threatened preterm labor, the specific condition that prompted the admission becomes your principal diagnosis.
Let's see this in action with Section 4, Common Inpatient Maternity Complications. You'll see these two quite a bit, and it is vital to distinguish between them. Placenta previa physically blocks the exit, interfering with the normal delivery. Placental abruption, on the other hand, is a very dangerous premature separation of the placenta from the uterine wall. The clinical presentations are completely different, right? So your code selection must accurately reflect the exact pathology the provider documented. The same strict differentiation rules apply when you're looking at things like gestational diabetes or preeclampsia. Then we have chorioamnionitis. When you see this documented, remember it's a severe, dangerous bacterial infection that requires highly specific coding. It infects the membranes surrounding the fetus and the amniotic fluid itself. It's a huge deal clinically, and it acts as a major driver for DRG shifts because of the intense resources needed to treat it. Finally, let's wrap up with Section 5, Reporting Outcomes and MS-DRG Impact. Because accurate clinical coding ensures accurate hospital payment, we can't forget Category Z37. Just like gestational age, reporting the outcome of delivery is a totally non-negotiable step for a complete maternal chart. You've got to capture this to show if the outcome was a single live birth, twins, a stillbirth, and so on. It basically puts a bow on the whole narrative of the inpatient encounter. And this is exactly why your specificity matters so much. An uncomplicated delivery groups to a basic DRG with much lower reimbursement. But when you accurately capture conditions like chorioamnionitis or severe preeclampsia, those act as a CC or MCC, a complication or major complication. This significantly bumps up the DRG's relative weight and payment, making sure it matches the intense level of care the hospital actually provided. All right, let's test your knowledge to make sure these building blocks really clicked. Pop quiz time. If a patient delivers at 38 weeks with severe preeclampsia, what's the golden rule for choosing the principal diagnosis? And what 2 mandatory secondary categories must you include? Think back to that 1, 2, 3 algorithm we just talked about. Got your answer? You sequence the severe preeclampsia as the principal diagnosis because it's a clear complication, which totally rules out that 080 code. Then you make absolutely sure to include Category Z3A for the 38 weeks gestational age and Category Z37 for the outcome of delivery. If you got that right, you are well on your way to mastering inpatient obstetric coding. So next time you open up a complex maternity chart, I want you to ask yourself, are you capturing the complete clinical story, or are you leaving critical reimbursement on the table just by missing a simple Z code? The details matter for sure. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep practicing those sequencing rules, always check for your Z codes, and I'll see you in the next explainer.